ones. That's it. So you see, this one is an old one. Okay, so which of the following serum hormone levels help determine whether hypogonadism is primary or secondary? Hypergonadotrophic versus hypogonadotrophic. Which one is it? Perfect. Yes, right? Feedback loop. Refresher. Again, know this so you don't get confused. And then you can tie this to the diseases, right? Okay. Here's the reason why. TSH is super important, just not this time. Same with cortisol. We're doing with males, not really focused on the estrogen. You get to learn a lot about estrogen, progesterone, and menstrual cycles, and all of that stuff in senior semester. I refrain from going too deep into it. And obviously, testosterone is low in hypogonadism, but not determining the etiology. All right, so how does increased sex hormone binding globulin contribute to the symptoms of hypogonadism? This is a little more nuanced, which is why I'm asking it in group setting. Does it inhibit prolactin, increase testosterone production, bind to testosterone, reduces compatibility, which I think a lot of people like, increase androgen receptor activity, or what is HBG? Perfect. It binds. Remember, that's if there's free testosterone and the total testosterone indicates the HBG bound testosterone. We get both. When do we order labs for testosterone? When do we order it? Random, fasting?
Morning.
Morning. Before 10, ideally between 8 and 9, 7, if your lab opens up early. Non-fasting is not, I'm not going to test you on that because I can't, and again, because glucose, our food will impact the testosterone level. Can I just do one and done with this, or multiple, right? At least 2 to 3. Right here. We're tying how the hormone normally is in the body and found in the body to our labs, right? To clinical practice. Helps us remember. And then obviously, dopamine inhibits prolactin. Luteinizing hormone plays a role, or is the driver of testosterone production. Receptor androgen activity, not in my class. We think androgen receptor activity to improve that. It's like lifestyle stuff, so the weight resistance, exercise, diet, all the things we should all ideally be doing potentially help with that. And then when we go to C, you guys all got that right. What does anyone remember? This is very nuanced. I know you were thinking of ortho, and I didn't hit it too hard intentionally. But what is the correlation between SHBG and low testosterone? So what you'll find is as men age, SHBG levels increase. And is that correlated to what that natural drop in testosterone? Obesity, so an old and obese male will probably have less of that free testosterone. Hyperthyroidism plays a role that you don't need to know. Estrogen, because some of these people aren't just on testosterone, they're playing with other things, not HCG and other hormones. Anorexia, so if there's food deprivation, intentional or unintentional, and then anticonvulsant seizure meds play a huge role in this as well. Okay, next question. We have a 2-week-old male seen for a well baby exam. So they get seen for the newborn check right after the hospital, and then the 2-week, 2-month, and so on and so on. He was born term via an uncomplicated, spontaneous vaginal delivery with no perinatal complications. Okay, nothing, no red flags. Physical examination reveals non-palpable testes bilaterally. Okay, so what is that? Potentially, non-palpable testes, they're undescended. What's the word? Hyperthyroidism, right? Most of the time. Which, if we were going to do an HCG stimulation test, which we're not going to, but let's say we did at some point in this baby's first year of life, which HCG stimulation test result is most consistent with a diagnosis of cryptorchidism? It's not bilateral anorexia. Increase in serum estrogen, no increase in testosterone, no increase in cortisol, that one. Increase in serum testosterone, or decrease in progesterone. Any guesses? I'm giving HCG, and that works like LH. And so what does LH do? Increases testosterone. If there are cryptorchidism testes functional, yeah, right? Yeah, so we would increase in serum testosterone, and 25% of the time, what does that testy do? It descends. Well, both of them in this case. So again, how many times do you think I do this test? Pete's background. I don't know, I've never done this test. But it's super cool, and I like, that's why I added it to like the group discussion. Super cool, especially if like they're older, like closer to a year of age, because again, most of the time this will resolve on its own, and we only need surgery after a year old. But again, we're going to do it when you have undescended testes, specifically for the two diagnoses, right? Bilateral anorexia, so no testes and they don't function, or cripplings. Perfect. Here's the bilateral anorexia slide where it compares both. He's got it. Okay, here's a fun one. All right, we're going to do this together, and there's a few slides on this one. So we have a 15-year-old girl. I'm just going to jump ahead because it's long. A 15-year-old girl is accompanied by her parents for primary amenorrhea. So that means she's not started her menstrual cycle by the age 15. Is that concerning? Yeah, usually it started by now. She denies, and delayed puberty. Okay, so lack of puberty and amenorrhea. Are we concerned? Yeah, right? This isn't just a regular sports physical. She denies sexual activity, does not take any medications or supplements, and say she's a good student, plays basketball. Physical exam, her height is the 90th percentile, so she's taller than 90% of girls her age. Weight, 50th percentile, so right in the middle. You do a breast exam, and it's Tanner 1 to 2. So you can see here on the right, staging is no breast development versus first signs of breast development. So she should be farther along, because secondary sexual characteristics like breast development usually comes prior to menstruation. So she hasn't been shown that. No axillary hair, no pubic hair. Again, the secondary sexual characteristics aren't happening. Which of the following is the most likely diagnosis? Androgen sensitivity syndrome, Klinefelter's, PCOS, Turner syndrome, or XY dysgenesis? Okay, what can we rule out? PCOS, because we haven't talked about it yet, right? But maybe after today that can stay on there. What about Klinefelter's? Why can we rule that out? Yeah, it's a female, yeah, at least for now, female. And then Turner syndrome, have I talked about that? It's a super fun genetic condition, but it's not in my class, unfortunately. So we can right away knock out 3, and so we're down, so there's the answer, but how do we get there? We can knock out those 3. Okay, so we're a 50-50 shot. Why is it XY dysgenesis over androgen insensitivity syndrome? What will help me get the diagnosis? What should I give you if I'm going to put this on a test? I do a physical exam, a good history. What do I do next? You know? Labs. What labs should I get? A bunch of them probably, because it's primary amenorrhea. It tests that free total testosterone and FSH and LH. So that will help me. And then with XY dysgenesis, what would you expect the testosterone to be? Non-existent, right? Dysgenesis, they're not, the testes aren't functioning, right? It's a genetic issue in the SRY, we won't go into that. So an XY dysgenesis genetic issue where the testes didn't form in utero, so she's phenotypically female, but XY genetics. Androgen insensitivity syndrome, what does that tell me is going on? What's the problem? The body's insensitive to androgen, meaning there's plenty of androgen in there, right? And this is what genotype is this person? Because we're in XY, right? So what happens to an XY genotype patient during puberty? Increase what? Androgen, increased testosterone. So what do we expect the labs to be in this? If it's that one, high testosterone, right? Okay. So here's the XY dysgenesis. Remember, it's a female, delayed puberty and primary amenorrhea, female phenotype, labs, no testosterone, increased LH and FH, right? Because you have this dysgenic testes that aren't functioning. Versus androgen insensitivity, they're phenotypically female. It's inactive receptors. So again, the HPA axis works, but insensitive to the androgens. You can't do anything with it. Why would these patients have breast development? Aromatase, right? With excess testosterone, it could potentially, maybe you should get like a Tanner 3 or a more obvious Tanner 2. And then why do they still have amenorrhea? Yeah, they're XY, because the embryological hormones, they didn't have testosterone to fully develop into male external genitalia, secondary characteristics with DHT, but they have a blind pouch. All right, so if I'm going to give you one of these scenarios, what should I need to give you labs too. And if you get stuck, go back to the name, XY dysgenesis, androgen insensitivity syndrome. And then you easily got rid of these ones. Okay, good job. All right, this is lesson 10, gynecomastia. Man, we've talked about this back, the first time we talked about it was with prolactinoma in lesson 3, right? It's a male condition where you have proliferation of benign male breast tissue, okay? It can be glandular, which is like more discrete, or like fatty tissue, so we'll talk about that. But again, the key is it's benign. Is all male breast tissue benign? No, so what's in the back of our head? Cancer, right? Breast cancer. And you're also going to learn there's a correlation with testicular cancer too. So again, true gynecomastia is benign. It can be unilateral or bilateral, symmetrical or not symmetrical, painful, non-tender. So we're going to dive into all of that. We're going to go through different etiologies. Again, most of them physiological or normal. Talk about the scary stuff. Man, do you guys think there's a lot of meds that cause gynecomastia? Yeah, there's a lot. There's one prescription in particular. Yes, spironolactone. Testosterone too can cause gynecomastia. And then we'll do, what labs do we do? Who needs labs and how do we treat it? We will get through this and 11 today. So, I need to post 12. It's not 88, but I'm going to post anyway. Sorry guys, I forgot to do that. Okay, so gynecomastia, we can't start it out without going through our feedback loop and some general terms. We'll start there. Presence of palpable breast tissue in a male, or we talked about, it could be asymmetric, bilateral, or unilateral. And then it can be at the bottom. Glandular is where it's like discrete nodule, and it's usually slightly tender, or the fatty gynecomastia. So the gentleman closest to the left is a more fatty gynecomastia. So you're not really feeling a discrete nodule as much as the excess fatty tissue. Benign condition, I already said, but we still have to just rule out carcinoma, breast or testicular cancer. And then etiology. So it's essentially, there's a lot to this, but it's an imbalance of estrogen to androgen ratio. So if you think about it like that, I think that's all I want you to think about, right? Because you can have high testosterone and have gynecomastia. You can have low testosterone and have gynecomastia. The take home is it's an imbalance of estrogen versus androgen. What androgen I'm talking about mostly is testosterone, right? There's other ones too. Or a deficiency in testosterone. Okay. Again, we're building on what we already know. Here's our same feedback loop as before, right? You have your HPA axis, gonadotropin releasing hormone, and the anterior pituitary releasing LH and FSH, stimulate the testes to produce testosterone. Testosterone goes and does its thing, peripheral. It can be broken down from testosterone to 5-alpha reductase, and that's how you get your DHT. And that's kind of like your viralization, so like your deeper voice, male pattern hair changes and things like that. But also it can be aromatized through in the periphery and produce estrogen, and that's what's going on. Again, it's a mismatch of androgen versus estrogen or a testosterone deficiency that causes this. Okay. Here's another breakdown, and it just dives into, it shows that we're, right, that last slide all talks about this testosterone. But remember the adrenals? Remember back we talked about adrenals a lot, specifically the cortex? It also plays a role in over 95% of the cause, but there's a different path. The endostrodione, right here through the adrenals, it correlates with testosterone, but then it also produces estrogen, okay? So we have two pathways to get that imbalance, okay? Adrenals, but again, the primary one is your testes, testosterone. All right, that's it for a review. Kind of went slower than I thought, but we're building on what we already know. All right, etiologies. There's a lot. We're not going to go through it all, and we're not going to go through that long-ass list of medications. We're going to just do the take-homes, and you'll essentially know what I care about the most, right? So whether it's physiologic, an endocrine disorder, or something else causes the imbalance, of stimulation of estrogen inhibits androgen, and we get gynecomastia. All right, so here's your physiologic. There's 4 ways. The first one is neonatal. So the percentage on here is super annoying. 60 to 90% of it. Okay, usually it's not this extreme or severe. Because if you've never done a little baby exam and you see that, or if it's your kid, imagine as a parent, they're probably going to be a little concerned because it does look red and inflamed. But again, this is neonatal gynecomastia. It resolves on its own within 2 to 3 weeks. So a lot of patient reassurance, right? Give it time. This is related, Mom, to your hormones, that estrogen that they're exposed to, and it should improve. Obviously, if they have like a fever and it's red or hot, you would do something different. But I'm not teaching about mastitis, I'm just teaching about gynecomastia. Okay. So again, reassurance. Confidently say reassurance, and that will help too. Next and the most common is your prepubertal physiologic gynecomastia. You've seen this at the pool. If you have kids, they might have had this. Up to 60% of boys. Again, it's benign, it's physiologic. They don't have to be overweight to have gynecomastia, but it's more common. But they can be tall and thin as well and have gynecomastia. Absolutely unilaterally or bilaterally. I think all of these are bilateral. There's some asymmetry on the kiddo on the far left. But unilateral is fine too. Do you notice where, at least in the first kiddo, where the gynecomastia is localized? Kind of central under the areola. That's really important, and we'll talk more about that soon. Tender, if it's that discoid versus just fatty gynecomastia. And again, usually that nodule is 2 to 3 centimeters in diameter and localized beneath the areola, so that's reassuring. How do we treat this? By observing. So you're going to tell mom and dad, I know maybe they're embarrassed because of sports they play or locker room or swimming, but again, just knowing this is normal physiologic condition that will get better in 1 to 3 years. Okay. Obviously, if their BMI is on the higher side, it's your opportunity to push lifestyle modifications. And again, reassurance. You can go back to your feedback loop and say, hey, right now they're going through puberty, so we have a jump in testosterone. And so maybe there's this mismatch, right? The estrogen is peaking before the testosterone gets to do its thing, and that androgen takes over and improves this. But again, you can use a very simplified one of these when you talk to your patients and parents to explain that we're just going to monitor. Okay. Aging is another cause. Occurs in 1 out of 3 males over 50. Okay. Associated with weight gain, that makes sense, right? Yeah. Just the excess weight, excess fat tissue mismatch, that testosterone can get aromatized and create gynecomastia from estrogen or estradiol. Testosterone levels decrease, we already know that, right? As SHBG goes up in just time, that decreases, so that's likely the underlying cause of this too. And then again, a lot of these, not all, but a lot are fatty pseudogynecomastia, so that's like excess fat tissue that causes it. This should be no surprise. Obesity is the last cause, right? Pretty classic, just building on what you already know. increased aromatase activity, also a decrease in testosterone, potentially. If he's, again, over 50 and obese, he's hit twice. Why do I have this in here again? I think it's just, know that it's not just testosterone, there's an adrenal component, and then a mismatch can be from either pathway, and then pharmacologists use these pathways to decide if someone needs treatment, or what treatment we have. Do we treat any of these physiologic conditions? No, no surgery, no nothing, no. Okay. All right, so that's physiologic. Then we have endocrine abnormalities. This is just one slide, right? Hypogonadism, we talked about that, right? Where it's the, again, mismatch, and we have low testosterone. Klinefelter syndrome was yesterday with the XXY. Not everyone with Klinefelters has gynecomastia, but everyone with gynecomastia has Klinefelters, but there's a correlation. Hyperprolactinemia or a prolactoma, right? That excess prolactin. A lot of times they don't come in until they have the headache or the vision changes or the low libido. A lot of those males will also have gynecomastia. Androgen insensitivity syndrome, right? Where it's phenotypically female, but XY genotype, and we're getting some gynecomastia, so some breast tissue. And then thyroid. So the thyroid disorder, it's FYI, because it was the last lecture, or the last block. But again, that has to do with SHBG in a hyperthyroid patient. Again, FYI. One slide only because we've talked about this in other places already. Right? It's building on what we already know. Then we have systemic diseases, so such as liver and chronic kidney disease. They can develop gynecomastia. So this gentleman, I think he said, he has liver disease, so not healthy otherwise, but if he comes in complaining of gynecomastia, yes, we'll still do the exam and discuss it, but in the back of our minds, we're going to be like, oh, okay, this is related to his liver disease, right? It's chronic disease. So you have cirrhosis, and things like that. Psoriasis. But yeah, 60% of people with liver and 52% with chronic kidney disease. Neurologic disorders, leprosy is Hansen's disease, and then starvation. So they learned this from POWs from World War II that were restricted calories for obviously a long period of time, amongst other things. And they developed gynecomastia. So again, that kind of correlates with the anorexia we talked about a few slides ago. Not a heavy hitting slide, just more like awareness slide per se. Okay. Then this is absolutely important, right? We're dealing with neoplasms or cancer. And there's a couple types. So testicular, ectopic, or breast cancer. The ones I need you to know for sure is your testicular and your breast cancer. Okay. And luckily for testicular, we have obviously a testicular exam, but not all testicular exams will show an abnormal nodule. So thankfully, we also have labs we can do. So we'll go into that and the labs. So testicular cancers are usually germ cell carcinomas, and for whatever reasons, they will excrete these extra biomarkers. And so that is helpful for us in screening, right? We can do some labs. And then breast cancer, specifically to males, is much less common than females. But you have to be able to determine through a physical exam or a history that something's not right. And specifically, it would be unilateral, but again, unilateral gynecomastia alone isn't a thing, but it's irregular, right? It can be painless, but it's also fixed to underlying tissues. It's not located right under the areola, it's somewhere else. It happened really fast. Maybe they have a history of radiation or family history of breast cancer. There's bleeding or nipple discharge. Is that normal in males or females? Absolutely not, right? And then do you remember Klinefelters? They have an increased risk of what? Breast cancer, right? What type of cancer do people with cryptorchidism have an increased risk of? Testicular, even if we fix the problem. But Klinefelters is that XXY, it's breast cancer, it's osteoporosis, it's blood clots, right? So definitely patient education is important, parent and patient. And then obviously, I'll just mention it, but obviously you could have an ectopic cancer who's producing a specific biomarker that's not testicular cancer, but for simplicity, just those two neoplasms are more important. This is a gentleman who came in like this. Male breast cancer is really aggressive. A person that waited this long would not do well. They don't do well. Why certain people ignore things versus others, I don't know, maybe they're scared. But again, obviously it doesn't take much to know that that is scary. He said there's lots of medications that correlates to gynecomastia. You guys know spironolactone already, right? You know exogenous steroids and androgens can correlate with this, especially if they're not under the monitor. Even if they're being monitored by a men's or concierge clinic or online clinic, you can still get gynecomastia. But especially if they're doing it on their own, there's that risk. And then there's other medications too. So if you're on an H2 blocker for GERD and it's causing gynecomastia, what would you do? Switch it, right? Lower the dose, switch it to a PPI or something. Ketoconazole is an antifungal, you're usually not on it very long. There's other BPH medication besides finasteride that you can use. But spironolactone, you can do a different one. Say they have primary hyperaldosteronism, and they're on that, you can maybe switch to Parallel, even that's more money. And then I guess marijuana and alcohol, they play a role as well. All right, feeling okay? All right, physical exam. Where are we gonna look physical exam wise? What's part of, obviously heart and lungs, right? I mean, you're in an OSCE situation where I think there's any gynecomastia on the OSCEs on Friday. You do your full history, you do your including your review of systems and your past medical history, all of that stuff. What do you check first? Vitals, right? Repeat vitals, and then you get your general appearance. How does it look? How does the patient look? Sick, not sick. Heart and lungs. What's the key for an OSCE when you do a heart and lung exam? Take this off. No shirt, no shoes, no OSCE. Okay, take this off. No shirt, no shoes, no OSCE. Heart and lungs. Now what do? You're coming in for gynecomastia. Where do we go next? Breast exam maybe, do a thyroid exam and testicular exam. Okay, we need to do all of that. Thyroid is just important to do. Testicular exam, is there asymmetry? Is there a nodule? Is there, not all masses are cancer. That's what you're gonna learn next semester, but it can be, there's very like hydrocele and epididymitis, there's all these other things that are not cancer. You absolutely need to do a testicular exam. And the benefit with testicular exams is you're gonna teach them to do a self-testicular exam, right? So they're gonna catch it way before anybody else, because that's, something they're the most familiar with, right? So self-testicular exams, and then of course we're gonna do a breast exam. The breast exam will help distinguish if it's glandular or that pseudo-fatty gynecomastia. You evaluate them laying down, and you're gonna palpate, check for any discharge. But before I even palpate this patient, what should I do part of the breast exam? The same thing we do for the GI exam or an MSK exam. It's the first thing I do. Inspect, right? I'm gonna inspect, and I'm gonna inspect with them sitting, and I'm gonna inspect with them laying down. I'm looking for dimpling, so like, or inversion of the nipple. Has that always been like that, or has it changed? Any like sores or anything like that. Very similar to your female clinical breast exam. So again, seated and supine, you're inspecting. You're also pulling for lymph nodes, axillary lymph nodes, and then you palpate. Looking for asymmetry, which isn't always bad. Tenderness isn't always bad, but location, right? Is it 2 to 3 centimeters under the areola? That's okay usually, right? For gynecomastia, no other red flags. Is it fixed to the skin? That's a really common thing. And then dimpling and that sort of stuff. So you have your suspicion of malignancy. For females, man, I image a lot because breast cancer is sneaky, and you're gonna see it, you're gonna diagnose it, they're gonna catch it and come in and you're gonna work it up. So Again, but I'll stick with males only. So then paying attention to suspicious of malignancy in what you do. All right, I'm gonna keep going. How do we diagnose? So you can diagnose this clinically, right? Especially this physiologic, like the neonatal, obesity, aging plus obesity, or that pubertal gynecomastia. But if they had it's like a really rapid, recent onset, tender or not tender, doesn't always gauge if it's cancer or not. But they're a lean patient with no other etiology, maybe they're older male, that's suspicious. If these are the labs that you would want to do, we'll break them out in just a minute, and I think most of them make sense. And you have two new labs at the bottom, serum beta HCG and the estradiol, and those are associated with biomarkers that testicular cancer produce or excrete. And then obviously karyotyping if it's indicated. What other signs and symptoms do I need to go for karyotyping for Klinefelters? Not just gynecomastia, what else? Small testicles, firm, small, non-tender testicles, unicoid proportions, right? They have the wide hips. Their arm span is much longer than their height. Maybe some social skills issues, mild learning disabilities. But they're having some puberty development. And then as an adult, they would struggle with fertility. So again, not everybody with gynecomastia gets genetic testing. You gotta put all the pieces together. All right, looking at each lab, this should make sense. We want to check prolactin because we know the prolactinoma from last block. Excuse me. TSH and FSH, we're always going to check that, and you don't have to memorize that one, but again, it's associated with the imbalance of SHBG. Testosterone, FSH, and LH, we got that, right? You learned that last block in block 9. We're already going to check that, and it'll help. Is this a primary or secondary? Hypergonadotrophic versus hypogonadotrophic? Is Klinefelter's hypergonadotrophic or hypogonadotrophic? XXY. This is the SRY issue. Yeah, hypergonadotrophic, right? So the failure is in the SRY. It failed to have testosterone and spermatogenesis in the testes, so it's primary. So again, the problem is the testes, pituitary response by increasing FSH. And then we have our brand new 2 labs. Again, I'm suspicious of cancer either from a testicular exam or something, their story, something's off. And I'm going to order a beta HCG to help identify if it's testicular and an estradiol, right? Should these be high in a male? No, right? This is indicative of a germ cell testicular cancer or something else. But again, you can see what I have highlighted is the testicular tumors. So now, I mentioned we don't have to work up every single person with labs, but something from their story is a red flag, right? If they have a known, I won't do this down in the test, but if they have like a known liver disease, chronic kidney disease, medication that is causing, they're on spironolactone, do I need to work them up? No, not necessarily. You can, but it's not required, right? If you have an underlying condition known to cause the gynecomastia. Imaging, I think, is pretty intuitive, right? So if I'm worried about breast cancer based on what? That physical exam, that's not your normal gynecomastia, I'm going to do an ultrasound with a biopsy, so the FNA would take a sample, and a mammogram, okay? So ultrasound and mammogram for suspicious findings. Real life, you do both at the same time. Current is very specific, so I have what current is, but you would order both. You'd order an ultrasound with a biopsy and mammogram, boom, boom. A lot of times if you just do the ultrasound and it's abnormal, they'll automatically order the mammogram. But again, we do that. And then labs, why are we doing these labs? Because it helps to rule out or determine is there a testicular cancer, and if they're high, I want to do a testicular ultrasound. If that's normal, then you would do a CT for looking for these other types of ectopic cancers. Okay, make sense? It all is building on. I think this is pretty intuitive treatment workup. If you remember testes and breast for cancer. All right, treat it. We already know this. Neonatal, give it time. Puberty, give it time. We're gonna observe, reassurance, lean on our feedback loop if we need to. Medications, let's switch it. Obesity, what could they do? Lifestyle modifications that we talked about in lesson 7, 8, and more, and more, and more, in lesson 8, right? So that sort of thing. Talk about all these. Okay, so just examples. Okay. Now, if you have a person, this is going to be rare. I have yet to treat anybody for this, but they have painful or persistent gynecomastia that it's not getting better. It's not due to a medication. They're older. It's interfering. You can't give them a SERM. Tamoxifen will be effective in decreasing the glandular tissue more so than the diffuse fatty pseudo-gynecomastia, right? Because that's extra fat tissue. But it is effective in reducing the glandular gynecomastia. And it's not forever. It's just a few months. Now, tamoxifen comes with its side effect, right? Which I won't quiz you on. But again, it's helpful. And then aromatase inhibitors are another option that you could do. I made that FYI. When I was talking about the Britain group of dudes, sorry, they're grown up. Group of guys who are doing the cyclic testosterone treatment, a lot of times they'll use aromatase inhibitors in that process. And then of course, you'd want to treat the hypogonadism, right? If the hypogonadism is the cause, you will want to do that. But testosterone can improve it or it could cause it, right? So you have to make sure that they're aware. Now, of course, if you have a male who's on testosterone supplement and he develops gynecomastia, you can't just be like, oh, it's your testosterone, you're good. You still have to do the physical exam, right? Prove it to yourself that this is truly just gynecomastia, right? If there's anything suspicious about it, you know what to do to work it up with the labs and potentially imaging, okay? And then surgery is reserved for that persistent and severe, and there's a before and after of a gentleman who had a reduction, I guess, or surgical treatment. So that would be more for like your obese male maybe, especially if they've lost the weight. Remember, those skin folds don't always dissipate at the same rate as the weight loss, so you can use it for that. That's it for gynecomastia. Pretty straightforward. Let's do the clinical stuff, and then there should be time for a break. Cases. All right, your first patient of the day. Not an ortho patient, gynecomastia patient. You're seeing a kiddo, a 15-year-old male. He has tender right breast enlargement for 9 months. Is that scary? 9 months is not rapid, right? 15, not super scary yet. He's a high school wrestler, but he's embarrassed in the locker room. He denies any medications, vitamins, supplements, so he's not doing testosterone on the side, so he claims. Is he obese? Looks thin, right? What else? So he's not obese, but again, it can still happen. Would you call this glandular or the fatty pseudo? Glandular, right? Is it asymmetrical? Yeah, only on the right you confirm that. So you would look for any changes in the nipple, crusting, dimpling, and then you would do a breast exam. So you go ahead and do the physical exam. BMI, what class obesity is BMI 21? None. All right, none. Vitals are okay. His arm span equals height. Happy with that. Not unicoid. Hopefully you can see. Chest. Asymmetry noted. You guys already got that. Right side gynecomastia, sitting, no nipple inversion, dimpling, or lesions. The physical exam documentation is super important. Okay, it's important for women. For breast nodules, it's just as important for males, even in a young man. Palpable right breast tissue below the areola, measuring 2 centimeters in diameter. The left breast exam was normal. No nipple discharge. No axillary lymphadenopathy was headed. Thyroid is fine. You do a scrotum or a genital exam, and it's normal. Testes, scrotum, and penis. No masses, no epididymitis, no swelling, which would be a hydrocele. And hair growth is normal. He's at Tanner stage 4, so he's where he's supposed to be. So less concerning for one of those genetic conditions, right? So now what do you do? So, do we do labs? Who wants to do labs? Who doesn't? Who's just gonna observe? So me, on this guy, I would not do labs. But if you do labs, that's okay. If you do labs, what labs are you gonna do? Testosterone, FSH, LH, prolactin, TSH. What are those scary ones that rule out cancer? Beta, SGG, and estradiol. So you don't have to order labs for this patient, but if you do, so your what's the word? Your not discretion. Your threshold for ordering labs will be fine-tuned to what you do clinical medicine. Okay, just like in Clinicor, when you have like a URI or acute gastroenteritis, sometimes you order labs. Most of the time you don't, right? If you're getting better. Same with this. This is a physiologic pubertal gynecomastia. But if you choose to, it's okay. Just this is every lab you order, you own. Again, the decision factor will be obvious when you're in clinic, even more so. Everything's normal. All right, what's the diagnosis? What do we got? Gynecomastia, right-sided. What's the cause? Pubertal physiologic. Perfect. What do you treat? How do we treat them? CERM, reassurance, reassurance, observe, talk to them. If mom's like, or dad is like, no, absolutely, you can go back to your feedback loop. Healthy diet and exercise. I mean, he's not obese at all, but with wrestlers, you want to make sure they're eating healthy, things like that. Okay, so we can take a break, unless you guys want to go a little bit longer. We're at 42. Let's push. Oh, okay, let's just do a break. Or no, wait. Don't stop a mark. What do you guys, let's just do a break. We'll come back at 52. We're gonna come back at 52. I heard like brr, and I didn't know if that was break or something else.
We're soft.
It's okay,
Old age.
Hold on. Yeah, so I'll be so I'll be free after.
Sugar free.
Oh, we did. Yeah. No, honestly, you'll probably finish up here, so I probably won't read it there. But yes, just. But yeah, Wednesday afternoon, it's on the, Wednesday after, I definitely. Yeah, I don't know, Wednesday. Oh, yeah, that's, okay, perfect, yeah, so then I need that. Thursday, I will after, Endo, I'm sure, I have a lunch meeting. Yeah. Okay, yeah. Okay. Yeah. Okay, good. But when I see that, like, I don't practice habit, because when I see that, I was like, oh my gosh. It's not black and white. But if they're on it, and then like I had they ignite it, it will look different. But if they develop but that's all like mostly what yeah, same. Yep, same. And I would always like yeah, and I would kind of put the name parentheses so that you would really but yeah, but like the same brand, the big name, yeah. So, but yeah, it wasn't at all. But yeah. Exactly.
Pretty good. Like, the week after Parkers, I'm driving, so during the break, I'm driving her down. Yeah. So she'll start like the week after. Yeah. Well, either I do it or she does it by herself. And she got to take a car. So I've done it like so many times. Either her family's house in Jacksonville, 17 hours, and stop off midway in Louisiana. So do the rest of it. Stay with family for a day or two. I'm gonna take her to we'll take her to Disney for 2 days. She had like a nice little vacation before we start and then take her down. We had a sense of my family. Fly out of Miami on Friday.
Yeah.
Come back here, get graduated.
Is that gonna be after?
No. No, this is like this.
Yeah.
This is like
Yeah, that would be.
Oh, it's like
yeah, like next week, like after we finish
oh
like
my goodness. Yeah. I thought you meant like the beginning
her,
of phase 2.
no, like her first semester starts like week right after.
I got it.
So yeah, next week on Monday we're going to
So you're gonna do the entire summer.
I'll go to Georgia. While she.
Which is not too bad. It's not far.
So yeah, I'll go out there and then it's only 7 hours from Miami. So I can.
That's pretty cool.
Yeah, so about 4 days. So I try to get as
Yeah, because I don't want you to lose what you needed to break this down. I would come this week. Yeah, I can. It's only 2 hours.
I'll do everything. I'll do that.
Yeah, well, sometimes he has like, yeah, right. It's like, look
Yeah,
at
we can feel stuff where it's happening. Like if it does, yeah, I would do it for 2 hours. Nothing to do.
I mean, everybody should have this stuff.
panel campus. That's where I was do it. I wish it was that was so much out traffic, 25-minute drive. 25-minute drive, like even you take the 8.
That's without traffic, bro.
Yeah, so I feel like,
Yeah.
her because like stay at school like study, like that traffic control, like study, whole bunch of stuff. She is in the other lessons. What would you like? But I don't think her experience is with the as stressful as because it's painful,
But they're
yeah, but no, but that's another thing.
We're gonna test right away on your knowledge. You should get 100%, right? You were just ignore the fatigue from ortho, exam prep, and all of that stuff. Okay, so we're still in gynecomastia, check on learning. A 42-year-old male presents with enlarged bilateral breast tissue. Which of the following is a physiologic cause of gynecomastia? Hyperthyroidism, Klinefelter's breast cancer, obesity, or semaglutide? Yeah, obesity. Good job. As well as aging people, neonatal. Good. Yeah, this is why it's not the other ones. Okay, 29-year-old male presents with unilateral gynecomastia. Okay, no worries so far. Which of the following medical history information would prompt for a further workup of this patient, either with labs or imaging? Hypogonadism. Oh, we got our H2 blocker again, smitidine. We got our rapid growth, liver disease, or obesity. We need lots of red flags, but again, just that rapid growth alone is suspicious. 29-year-old male is outside of puberty. It's unilateral, and then again, that physical exam. Where is that nodule? Is it fixed to the skin? Is it outside? Is it not directly under the areola? Etc., etc. And then here's your breakout. No, all of them are known etiologies of gynecomastia. Okay, now we're totally shifting gears. Guys have gotten all the attention the last 2 blocks or lessons. We're going to talk about females with hirsutism. One way to remember how to say this is hirsutism, so like her and a suit. Now, yes, women can wear suits too, but it's the one way you can remember how to pronounce it. And then that we're talking about a female with what? What's the problem with hirsutism? Male pattern, hair growth, acne, all of that. Okay. All right. Hirsutism. So we're going to go through, obviously, the background. So we're talking about hormones again, because it's endo. We're going to dive into the different hormones, because there's 3 of them that play a role, and then the different types of conditions from idiopathic all the way down to cancer. Okay, we should get through it all. All right, back to the adrenals. So we have our testosterone feedback loop on males. I don't dive into the LH and FSH realm of females, because that's women's health. But you have to remember there's not just that testosterone loop, but there's the adrenal cortex, for cortisol, and what else? Androgens. Androgens are released. Okay, so that's really important to remember. The androgens act on sex hormone response when we're dealing with hirsutism. Okay. So androgens, there's 3 of them. What do you think is the biggest factor? Which androgen, I guess the only one you know per se, which is the biggest factor causing male-like testosterone, right? There's going to be 3 we're going to talk about, but yeah, testosterone. And what it does is it has a response on sex hormone responsive hair follicles, right? So again, this should make sense. The chin, the upper lip, the chest, axillary, abdomen, pubic region, right? And it converts these vellus hair, which is these unpigmented, super soft, maybe not super soft, but soft, thin hair, and fine to pigmented, coarse, and thick terminal hair. So dudes or guys or girls who have boys, or when you learn Tanner staging, this happens normally for males, right? You have the fine villous hair turns into the coarse thickened hair on their for mustache, axillary, and pubic hair, right? But this is happening in females in areas that not necessarily should. Androgens also can increase sebaceous gland activity, and that will correlate with acne and oily skin. And this is what it would look like, and obviously the definition specifically. This one is from Current. It says excessive terminal hair growth, so we know what that is now, that appears in women in a male pattern. Okay. Many women with hirsutism will have hyperandrogenism, but not all. Okay. So again, if you have excess androgens, that makes sense. So that's why you're getting this male pattern. But then there's idiopathic or even like hereditary hirsutism. We don't fully understand why. Maybe it's more receptive to androgens. But again, not all people will have that have hirsutism have an underlying pathology. Okay. So again, elevated levels of androgens equal the hirsutism. But then these people, there are people who don't have a pathology where we think they have increased sensitivity to the hair follicle or of the hair follicle to normal levels of androgen. So these are women who have normal testosterone levels, normal estrogen, normal androsterone levels, but have hirsutism. So their labs will be normal versus someone with PCOS, congenital adrenal hyperplasia, or cancer. They're going to have elevated androgens causing the symptoms. Okay. I won't go into that. Okay. So there's scoring. There's a quantitative scoring that you can use versus because like instead of just going subjective. Yes, they have male pattern hair. We do have the Ferryman-Galloway score. So this was created, I think, in like the mid-1900s in Britain, and they evaluated a bunch of women with hirsutism. And in different body parts, there's 9 different body parts, and you get a score of 0 to 4. And they determine your severity of hirsutism. But obviously, understand, so in Britain, you're missing the cultural factors, right? So Mediterranean, Hispanic women, black versus white women, so it does vary. So now we actually have different score guidelines depending on their ethnicity, right? Middle Eastern versus Hispanic versus Caucasian, okay? So you don't have to memorize this. I'm going to tell you. If I give it to you, it's going to be elevated or, and I'll make that clear. But again, they look at the different areas and you get a point system to determine a quantitative diagnostic tool to diagnose hirsutism. Okay, so we're going to dive into the hormones. Since I've been teaching this, I've added in like where the hormones originate because I think if you plant that seed, that it helps you remember them when it comes to labs, because that's what's going to be really important to you, not just on the test in the pants, but in real life as PAs. Okay, so you already know testosterone is the heavy hitter. If we look at testosterone, it can come from, it's released from the ovaries as well as the adrenals. And then in the periphery, testosterone can convert 50% of the time to androstenedione, which is our hormone in the middle, and that's also released from the ovaries and adrenal glands. Okay. And then your dihydroepiandrosterone sulfate, your DHEAS, comes from the adrenal itself. Again, this is like I'm not going to be like, where does DHEAS come from? But if you remember where they come from, it helps you understand what the abnormal labs need and where I need to do imaging. So it's kind of we're stacking it up, so you don't have to memorize that stuff. Okay. All right. So if I had crazy high DHEAS, where would I focus my imaging on? Adrenals, right? A CT. If I had crazy high testosterone over 200, where would I focus my imaging on? pelvic ultrasound, and then a CT as well. Pretty good. Now, if you're really, this helps you learn, here's your breakdown of the enzyme pathway of how we get all the different hormones. It's kind of fun, but again, different paths, sure. Okay. Not this class. Was that like biochem, maybe? No. If it helps you, there you go. All right, so let's look at the major androgens, testosterone in a female. Just like males, no surprise, we have our bound testosterone and then our free. But only 1% is that free active testosterone, right? And then that free testosterone is converted to DHT by 5-alpha reductase, so the same pathway we learned already. And it's that, and so when it's in excess, that excess testosterone gets converted to DHT, and what do we get? The male pattern hair growth, right? If it's crazy, crazy high, you're gonna see some more significant male pattern changes of viralization that will show when we get to the cancers. Okay, any questions? Okay, what's the most potent androgen for females that causes this? Testosterone, but it's not the only one, right? Okay. All right, so these are the different etiologies we're going to talk about. We're going to go through each one. Which one, if you had to guess, is the most common? We're going to touch on PCOS, specifically more related to the hirsutism, and then you're going to build on it even more in women's health. I'm sorry, refrain from, again, all of the menstrual cycle related hormones and endometrial complications, but yeah, absolutely. All right, let's jump in. So idiopathic, we've already alluded to this, right? In the Mediterranean, Middle Eastern females, when they come in, if they come in, right, why would they not come in? Because their sister had this, their mom had it, right? So they self-treat it, maybe on their own with waxing, lasers, and different things. Also, they're not coming in because it's just, they have normal androgen levels, and they have typically a regular menstrual cycle. Now, you could have a regular menstrual cycle and idiopathic familial hirsutism. But again, it's usually during puberty when hormones they start to increase. You have maybe their receptors are more sensitive to the androgens, and so then they get this. It's very slow and progressive, right? It's not rapid, it's not overnight. And otherwise normal physical exam. And there's the theory at the bottom. Sure. Make sense? So if you know idiopathic, have the family history, and they have a normal, regular menstrual cycle, anytime you're dealing with someone with hirsutism, what do you ask about? Their menstrual cycle, right? That's going to be a key factor. Specifically to PCOS, the most common cause of hirsutism. Okay, so it says 4 to 6%. I think the recent guidelines say 6%, but it feels like way more when you're in clinic. At least as a female provider, I feel like I see this a lot more common than 6%. All of you will see PCOS, whether you're in the Army or the Air Force. 50% of hirsutism is associated with the elevated testosterone. So again, what that tells me is that not everybody with PCOS has high androgen levels, but about half of them do. We don't know what causes PCOS. I was just talking to one of my freshmen who wants to do their PICO question on PCOS, and yeah, we don't know. Is it an HPA access issue? Is it insulin resistance? For sure there's a genetic component, but we don't know exactly which gene. So again, super interesting thing that we don't really understand what causes it. But to diagnose it is what I need you guys to be able to do. So there's specific diagnostic criteria. So if you're like somebody who likes metabolic syndrome because you have to have 3 of the 5, or diabetes, right? You need these labs to get the diagnosis. You may like this. There's 2 diagnostic criteria I'm going to go over. One is the current, and one is the Rotterdam that has been around forever. But they're essentially the same. Okay, so they must meet all 3. They have to have clinical hyperandrogenism, so that's physical exam, right? That's the hirsutism, the acne, the male pattern hair growth, or elevated free total testosterone. Okay, right? Not only 50% of them will have that elevated androgens, but they need to have essentially hirsutism, either by labs or by physical exam, or both. dysfunction not caused by something else. So it's not because of any other cause, cancer, or any of the amenorrhea etiologies you're going to learn next semester. So ovarian dysfunction with polycystic ovaries. Oh, I like that because that's the name, polycystic ovarian syndrome, right? It's in the name. Or oligoanovulation. So when I say anovulation, what is that? What is it? Sorry.
No ovulation.
Yeah, so they're not ovulating, so they're probably gonna have fertility issues, right? So it's less frequent ovulation or polycystic ovaries. So essentially, not everybody with PCOS has polycystic ovaries, but they either have to have polycystic ovaries or oligoanovulation. So a lighter menstrual period. They might go like 2 to 3 or 4 months in between menstrual cycles. That's a giveaway. Or they're struggling to get pregnant. Essentially, it's hard to get pregnant when you have cycles so infrequent, right? All right, so here's the Rotterdam criteria. It's what you might hear in clinic and maybe in women's health. It's changed from 1990 to 2003 and now 2009. Now let's look at 2009, that's all that really matters. It says, androgen excess in PCOS society says you must have A. A is hyperandrogenism. All right, that's the same as this, right? Either by labs or by physical exam. And they must plus either B or C, oligomenorrhea or polycystic ovaries. So essentially saying the same thing in a different chart. I just added this a few semesters ago because if you went to phase 2 without hearing this, I think I'd be doing a disservice. Okay. Feel okay so far? Diagnostic criteria make sense? All right, so from that, this is what we're going to see when we do a physical exam or do a medical history, right? Amenorrhea, oligomenorrhea, for infertility issues, polycystic ovaries in the majority but not all. Weight gain is a huge factor for PCOS, and it ties in this insulin resistance that they struggle with. So how rough is that? So you have a PCOS patient who has gaining weight, trying to lose weight. It's just much harder than the normal population, which we know from lesson 7 that it's already really hard for people to lose weight. And then you have your acne, oily skin, male pattern, baldness, or excessive androgen. That's all your hirsutism stuff, right? So you have both. And then there's the picture of the polycystic ovaries. I'll show you another one. And again, they might also have obesity is super common. I took this statistic out, but the vast majority are obese. Which came first, chicken or egg? I don't know. Is it the obesity, insulin resistance? Anyway, just understand that it's like really difficult for these people to lose weight. You also can have thin women with PCOS, which is tricky because they're still struggling with all of this other things, but they don't have the obesity and hypertension and all of that stuff, or at least look like that classic PCOS patient. Insulin resistance is a huge factor, obviously, that correlates with type 2 diabetes, sleep apnea, hypertension, and mood changes. Okay. All right, so that's it on just the etiology of PCOS. We're going to talk more about it and work up in just a minute. Now, the next thing is called sterogenic enzyme defects. Do you guys remember that congenital adrenal hyperplasia? We had less than 5, always 21, or never 21, always 17. Remember that feedback loop to get to cortisol? It's back, okay? I don't have the enzyme thing, but remember, these patients are deficient in 21-hydroxylase. There's a deficiency of that, so they never get to 21, so they never really, or less likely, they have much less cortisol if it's the non-classic, right? So decrease in this enzyme leads to an excess of 17 hydroxyprogesterone. And remember the classic is the baby that doesn't do so well. I'm used to tell you all of that. But the non-classic, they're still making some hormones. They're still making some cortisol. So we might not catch it until later. And look at these symptoms. Polycystic ovaries, irregular menses for menarche, gradual onset of hirsutism. What does that sound like? PCOS. So essentially, what do you think is more common, PCOS or non-classic congenital adrenal hyperplasia? PCOS, right? Only 2% of the time is it CAH. But anytime you're going to work someone up, you think they have PCOS, how do we quickly rule this out? A lab. Check your 17-hydroxy progesterone. So again, you always check this. Even if everything about it says PCOS, you always check this when you're doing the workup. Okay? And again, this is why, look at that, it totally overlaps with PCOS. Okay, now we're into the cancers. So this, again, we tie back to where these androgens are produced. These cancers make sense, right? Ovarian tumors, super, super rare, less than 1%, that's good news. Or adrenal cancers can cause this. All right, features also overlaps with what we talked about when we we're talking about gynecomastia, right? And our testicular and breast cancers. Rapid, severe progression of hair growth that's outside of puberty, right? It's not gradual. I don't know if all the women in my family didn't go through this, but it's rapid. I had a normal menstrual cycle for years, and then all of a sudden it's irregular. And then viralization, what is that? Viralization. It's like really pronounced male features. So their voice gets deep, increased muscle growth, male, and then obviously severe rapid male distribution. Even some of like their fat may change on their body, right? Maybe less abdominal and hip fat, and then they will change and lean out more like a male. Okay, clitoromegaly, where it wasn't before, and then again the voice change. So you see how all this is not PCOS? I don't know what it is. Something's not right, right? It's rapid viralization. They were fine, and then they're not fine, and it's severe. These are rare. This is an FYI slide. Rare causes, acromegaly, we already talked about, and then I don't need you to know all the medications for this. Okay. All right. So, clinical presentation is next. How do these guys present? You already know. You already told me, right? Male pattern changes. The acne, because of that increased androgen activity on the sebaceous glands. Oily skin. We always have to ask about menstrual irregularities, right? Or infertility. How frequent are their cycles? Family history is super important, right? And then again, if there's a red flag, why this doesn't sound like or just look like regular PCOS, right? It's more pronounced. Decrease in breast size, the loss of adipose tissue, which I mentioned already. The virilization, they're losing hair, they're getting a lot of muscle strength out of nowhere. Clitoromegaly, deepened voice. We need to rule out cancer and obviously CAH as well. Okay, red flags. So overlaps with PCOS and idiopathic, but it's very different. All right, so we're in Endo. We get a good history, get a physical exam. What do we do next? What do we always do next? Labs. Okay, what labs do you think? We're in a female. We learned about these androgens. Which labs? Testosterone. What else? What's produced from the adrenal? It's a really long name. DHEA. Yeah. And then the new androstenedione. We're going to do that one as well. Okay, so we're going to do all of those. But who do we do it on? Right? We're going to do it on the severe hirsutism outside of puberty, or mild hirsutism, but they have menstrual cycle irregularities, right? They can't get pregnant, that sort of thing. Virilization, defeminization for sure. And here's your key labs. Your testosterone is the most important, right? That's the most potent androgen. The androstenedione and DHEAS. And you can order them all at the same time. Okay? You don't have to do one and the other. Anytime we're doing menstrual cycle evaluation, we're going to do more than just these three, right? We're probably going to check the thyroid, rule out pregnancy, check prolactin, FSH, and LH as well. Okay, so looking at free and total testosterone, we know that only 1% of testosterone in women is free, but if it's in excess, it can go that be secreted to DHT and cause problems. But most hirsutism cases have only normal to mildly elevated testosterone. So that should tell me if I have a testosterone over 200, that is scary, because normal testosterone level for total T is 15 to 70. So this is scary, this is severely elevated, so is this. So what does this tell me? PCOS or something scary? Something scary. cancer is causing way too much androgen, and it's causing that fits with that rapid progression, right? Defeminization symptoms that you're seeing. And then if you have a crazy high testosterone, you would want to do a pelvic exam and an ultrasound. Current is very specific. You have to do a pelvic exam, and then an ultrasound, and then maybe a CT. Honestly, if I have testosterone like this, I'm doing a pelvic exam, pelvic ultrasound, and I'm also ordering a CT, okay? But there's like a stepwise progression to that. Why are we looking at the CT of the adrenals again? Testosterone that comes not just from the ovaries, right, with the pelvic ultrasound, but also can come from the adrenal cause, right? Remember that pathway. It's just a breakout again. Pelvic exam and ultrasound, and then a CT. Okay, and then these other labs, right? So if we have a crazy elevated androstenedione, excuse me, we need to work that up, right? Pelvic ultrasound and a CT. Makes sense. Super high elevated DHEAS, we're going to definitely look at the adrenals because we know that that's where it comes from. Again, these carcinomas are super rare, but we need to be able to identify it, and then we lose our normal physiology to determine what labs and what imaging to order. So markedly elevated for any of those goes to further imaging. Okay, additional labs, you guys already know this, right? FSH and LH to determine is a primary or secondary issue of PCOS. 17-hydroxyprogesterone, you know, from CAH and PCOS, everybody gets that. We want to make sure they're not pregnant, didn't have prolactinoma causing issues. And then why do I care about a glucose and a lipid? And then maybe an A1C. Why? Insulin resistance, right? Excess visceral fat causes insulin resistance. And these PCOS patients have an increased risk of type 2 diabetes and struggle more with obesity than Crohn's. And we won't go into Cushing's syndrome, at least on the test. Maybe a clinical case or something, but not on the test. All right, so this is just a review from the last one. I essentially already hit it when we talked about it, but if it didn't make sense, this is why we do 17-hydroxyprogesterone. Imaging, we already know. So pelvic ultrasound. So we're absolutely, anyone who has a markedly elevated testosterone, we're getting the pelvic ultrasound, right? Well, what if I just have mildly elevated testosterone? Or my testosterone is normal on my patient, but they have hirsutism. Do they earn a pelvic ultrasound? Yeah, right? Because of what we want to check for polycystic ovaries. So absolutely. Okay, I like really foot stomp the cancer one. But don't forget, just for just regular PCOS, even congenital adrenal hyperplasia, you can do a pelvic ultrasound. It's not as a scary thing. It's almost like a stepwise progression. When you have some of PCOS, a lot of labs, the ultrasound, and then a lot of different options. Okay? So again, we do the pelvic ultrasound for evaluation of polycystic ovaries and polycystic ovarian syndrome, or CAH, and then extremely elevated labs and adrenal CTs, same thing, super high labs. The MRI, you don't know. Here's what the polycystic ovaries look like. Yeah. 70% have it, 30% don't. Not everybody with polycystic ovaries have PCOS. Okay, so it's a piece of the puzzle and part of the diagnostic criteria for PCOS. All right, time to treat. Did you guys learn about treatment in pharm? This semester or last semester? Be who knows? That was a month, weeks ago, man. Okay, so we're gonna essentially, so I tell you, hirsutism is always caused, especially PCOS, it's essentially gonna be tailored to the individual. So we're gonna primarily focus on the hirsutism symptoms, but I can't not talk about a little bit of menstrual cycle irregularities because you treat both infertility just a little bit. So again, it's tailored to the specific concern, but it often becomes comprehensive. Why? Because sometimes it's just the hirsutism is the issue from the excess androgens, or a lot of times it's the menstrual cycles too. Fertility, you ask a patient, especially who has PCOS, are you interested in getting pregnant or not, and that determines what you do next. And then of course the obesity, hyperlipidemia, insulin resistance, hypertension, we can't ignore that, right? So we're gonna lean back on what we've learned in lesson 7 and lesson 8, right? So again, it's a lot of this patient can be overwhelming, just like diabetes. Oh wait, we can get diabetes too. Okay. We're gonna, obviously if there's a medication, we do a med scrub and there's a med causing it, let's decrease that or modify it to a different dose. And then if there's any underlying medical cause, don't worry about that for this test. Okay, so we're gonna aim right at the cosmetic issues for a patient with hirsutism. And there's creams, there's lasers, you can do threading, waxing. Dermatologists will have laser therapy. You can even now do like home laser therapy for hair removal. With the laser hair removal, it only works on the darker skin, or sorry, darker hairs versus the light. The cream, I thought it got discontinued. I think it's still out in the US, but it might be hard to get. But it works good when combined with laser therapy. But anytime you put a cream on someone's face, you're gonna have to watch for adverse reaction, right? Irritation, redness. A lot of times they don't come in, or when they come in, they've already been doing laser or hair removal, and you don't notice it, right? So again, there's some obstacles to treatment and catching it. But yeah, so this is mainly the topical hair growth. Minoxidil, that's your Rogaine. You could potentially use that for the androgenergic alopecia, but don't worry about that for the test. It's no big deal. Okay, oral medication is next, so that's your topical and your laser. We have oral medication, there's quite a few. A lot of this you already know and talked about, okay? So, we have, what's the criteria for PCOS again? Hirsutism, right? Either by clinical exam or labs. And what else? Oligo and ovulation, irregular menstrual period, or infertility. So it should make sense that oral birth control is going to be the initial therapy for someone with PCOS who does not want to get pregnant. Okay? Interesting enough, these are combined oral contraceptives, so it has estrogen and progesterone. Reduces acne, bonus, and the hirsutism. How cool is that? Okay, but again, not actively pursuing pregnancy. And they have this anti-androgenergic effect certain progesterones do, okay? So, but when I prescribe someone oral contraceptive, there's risk, right? You can't just give it to everybody. There's risk of DVTs, obviously if they smoke, migraine with aura. There's limitations, so we can't just give everybody oral birth control, so you have to be aware of contraindications, more so in phase 2 than in my test. I just need you to know that oral contraceptives are the initial therapy for somebody with PCOS not wanting to get pregnant. Now, it gets even more interesting. I guess that picture should be on here. There's a lot of data on this, and certain birth controls work better than others, okay? So as you will learn as you progress through PA school and life, that there's just certain ones work better. It'd be really fun to go through this, but I will not do that to you, okay? And there's some wiggle room when we prescribe combined oral contraceptives as far as which progesterone, how much of that progesterone, and how much of the estrogen, okay? So we can attempt to individualize treatment, okay? Anti-adrenergic, you have your spironolactone, right? It's potassium-sparing diuretic, which has anti-androgen action. So we're reducing the hirsutism symptoms. Awesome, so super helpful, and it's often prescribed with oral contraceptives. So if you do the oral combined contraceptives, so if you do those together, you usually have a better impact. Cannot give this to a pregnant woman though. So if she's seeking fertility, this is out the window. Finasteride, when do we prescribe for finasteride to males? Off-label. BPH for normal, and what if I decrease that finasteride dose in a male? For hair loss, alopecia, right? So you decrease it like a quarter of the dose, and you can give that So technically, maybe you can use that for women as well, but it's FYI, we're not gonna go into that, because, yeah, you have to like, it can affect, it's like, we don't want to impact if they get pregnant and things like that, but anyway, finasteride potentially, but don't worry about it. Metformin, it's good that you do know how to use it to prescribe it for males. TRICARE, do you think TRICARE covers finasteride for male pattern? It doesn't, how do you get around that? You prescribe it, you give them a pill cutter. You have to educate them, right? Pros and cons, screen for the PSA and things like that. But again, it's off-label use. And oddly enough, the guys who come in with it have like a full head of hair. Oh, okay, you won't. Maybe they're starting early. Alright, so metformin. We know this medication, right? It works through the liver, helps with which part of PCOS? Insulin resistance, right? We use it for pre-diabetes, type 2 diabetes. And alone, it doesn't touch the hirsutism, but if you combine it with spironolactone, boom, it can enhance the effects. Okay, so again, we use it for sure, it's money in your PCOS patient who also is struggling with hirsutism, or someone with just hirsutism and is struggling with the hair, male pattern hair growth. Okay. Improves menses. Oh, promotes weight loss. It's not crazy weight loss like SGLTs, but you have the potential for weight loss. Women's Health will start women PCOS patients on this high dose right at the get-go. But what are the adverse reactions for metformin? GI stuff, right? We can't use it in super crazy chronic kidney disease, marked for lactic acidosis. Anybody ever seen it? But again, metformin can be helpful for patients if they want to do that. Simvastatin, I think you put FYI by this. I bolded it just because it's interesting. But again, it can reduce hirsutism and testosterone levels. Again, it works better when you combine it. There's testosterone suppression medications, FYI, because you're not going to really prescribe those. Clomiphene has to do with, as Clomid is the brand name, has to do with fertility, FYI, in my class. Okay. So what's the first line for hirsutism and when you have someone with PCOS? Oral, and they don't want to get pregnant. Oral contraceptives, spironolactone, understand how that helps with hirsutism, that anti-adrenergic. If you add metformin to spironolactone, it enhances it, right? So the take on this is it's not just one pill, and unfortunately it's multiple pills, right? Like multiple things, potentially depending on what they want to do. And this is a PCOS specific, so again, do you want to get pregnant, yes or no? If they say yes, I go through a totally another pathway. If they say no, it's kind of what we've talked about. We're focusing on the hirsutism and their menstrual cycle irregularities, right? We want to potentially restore those menstrual cycles, again, or improve the excess hair growth, or both. Weight reduction is super, super important. These patients, a majority of them struggle with obesity already, insulin resistance. Does that make sense why weight reduction is primary in their treatment? If you want to get pregnant, you're telling them they need to infertility or fertility can improve with weight loss, okay? If they don't want to get pregnant, weight loss to prevent chronic conditions like insulin resistance. Even their menstrual cycles improve with weight loss. But it's not easy, right? So you're going to have to lean on all the things you know about therapeutic lifestyle changes to get individualized treatment. So this is PCOS seeking pregnancy. Oh, first thing on the list is weight loss. We're not seeking pregnancy, first thing is weight loss, right? Then you have meds, so the clomiphene is like pretty much what I prescribed for infertility in the past. The letrozole is a new fertility med that works better as far as ovulation and pregnancies, maybe metformin. And then you have, I'm going to screw it up, the myoinositol, it's a supplement. And studies are showing that that also improves insulin resistance as well as fertility. Acupuncture, if it works. For fertility, women will do it, and then obviously IVF. Surgery, so away from PCOS, just surgical treatment for cancers, right? So if we have adrenal carcinoma, ovarian carcinoma causing it, we're going to treat that with surgery. Yeah, not really high yield on this one because we're not the ones doing it. Okay, so maybe situational awareness on this guy. Take home cancer, severe, scary, do the labs, do the imaging, and work from. Okay, so we have all of those. Let's do some cases. Let's treat some patients. All right, so we have a female, 28-year-old female with a history of irregular menses. She struggled to lose weight. She's been struggling with her weight since age 15, so it's progressive, right? It's not rapid overnight. Complains of gradual increase in the amount of facial hair. Red flags? Not off the bat, right? Maybe how long has she had the facial hair is important. You do your physical exam. All I give you is vitals. What do you think of those vitals? What's that BMI? Plus what? 3, right? It's over 40. Do we like that blood pressure? No. But we need another one, right? You can just like call it hypertension just based on what? As far as what stands out in the history is weight gain, but it's been for a really long time, and then the hirsutism, right? But it's not rapid, right? And then we have obesity, hypertension. Okay, so you're going to have to be doing this soon with OSCEs. What should the physical exam conclude based on what you know? What do we need to do? Maybe do that Fairman-Galloway test, right? Sure. Should I repeat their blood pressure? Absolutely. Heart and lungs. No shirt, no shoes, no OSCE, right? Take that shirt off. Do we see any kind of like crazy purple striae or something related, right? We need to do that. What else? Should I do a pelvic exam? Maybe. Breast exam? Abdominal for sure, yeah. All right, what do we do? So general, they're sick, not sick, nope, they're fine, well developed. Cardiac, home. So when I do physical exam, my OSCE people know I'm like a head to toe person because that's how I was taught. Where I kind of built this like a little bit more like how you guys do it. So general, lung and heart, and we do a GI exam and it's normal. Pelvic exam, no external clitoromegaly, right? Because that would be causes of extreme androgens. She hadn't had it before, and it's a benign pelvic exam. I'm not doing a pap smear, just a pelvic exam. Skin, here we go. This is nice. Few terminal hairs noted. Areolar, on the nipple, of the chest, lower back, and abdomen. Significant number of terminal hairs along the jawline, upper lip, and upper extremities. Mild to moderate inflammatory acne. You call it different on a physical exam, but you guys haven't had derm yet, so it's called acne. You never just say it's acne on your history. The comedones, here we go. And then you do your Fairman-Galloway score, and it's elevated. All right, not the diagnosis. What's the problem list? What do we have to help this patient out with? What'd she come in for? A regular menstrual cycle. What else? Hirsutism. So hirsutism class. What else? Obesity. The blood pressure. What is this physical exam confirmed? Excess androgens or hirsutism, right? We have to do the labs to determine that because she could have normal levels and still have hirsutism. Does the physical exam tell me she has PCOS? Not yet, right? Okay, it's not just physical exam. We need to do a little bit more. All right, so we have obesity, hirsutism, acne, irregular menstrual cycles, possible hypertension. What do we do now? Labs. Which labs? All the labs, yes, testosterone. But root testosterone, I'm throwing in FSH and LH. What else? DHEAS, androsterone, thyroid, prolactin. Should make sure she's not pregnant. And don't forget, I know it's only 2% of the time, but CAH, congenital adrenal hyperplasia, mimics PCOS, right? So our 17-hydroxyprogesterone, always 17, never 21. Sweet, that's normal. Why did you order a lipid panel, CMP, and A1C? It's that clinical picture, right? The hypertension, the obesity. We know insulin resistance that these women with PCOS struggle with that. So what's high? Testosterone. testosterone. Is it crazy high? Is it markedly higher over 200? No, mildly elevated, maybe a little more than mildly elevated. What should we do now? We did a public exam. Should this person have an ultrasound? Yeah, so I want to check for, and maybe not for cancer per se, but for polycystic ovaries. So they're calling this patient has polycystic ovaries. Again, the hyperandrogenism is confirmed. She has irregular menstrual cycles. I didn't dive into that because we're not in women's health. So we'll just say that she has that. And then we would educate her on weight loss, right? When we utilize our consult, right? Because it's already hard for normal patients without PCOS to lose weight. So let's use our dietitian referrals, physical activity, behavioral modifications, obesity medications. Side note, GLP-1s and PCOS, you think there'd be a connection, right? If you give these women GLP-1s, their PCOS improves. It's not there yet. So more to come. It's still metformin, but maybe one day GLP-1s will play a role, but it hasn't yet to say. And then consider medications. Does she want fertility? No. All right. And then what do we focus on? She's upset at the weight. She's upset at these hyperandrogenetic features, right? She's upset about her menstrual cycles, I guess. So then how do we do it? Weight loss, weight loss, weight loss. OCPs with metformin or spironolactone with metformin. Or she can do laser hair removal. So if you like a dermatology clinic, they're kind of basics. I interviewed with this, I got a job offer out of baseball from this derm guy. He's a dermatologist, not a guy. And he was an army, he went to medical school with the army actually. And I interviewed with him and I remember I was like 27, 26, and I looked over in his arms. He had like baby skin. I'm like, oh, that's the benefit of being a dermatologist, because he's old. They have all the lasers that like change. Of course, like that. Okay, next one, Andrew Jenner. Andrew Jenner is a 45-year-old Caucasian female with a 2-month history of rapidly developing hirsutism. She has noticed a 24-pound weight gain, stretch marks, deepening of her voice, and absence of menses for 3 months. Red flags? Yeah. Rapid is scary. Deepening of voice, that's scary. First period was at 14. And I don't know, deepening, or these stretch marks. Let's do the physical exam. Blood pressure, are we okay with that? No, hypertension. BMI, what class are we? Bless you. Class 1. She's no acute distress, well nourished, well developed. You look at the skin, and sure enough, you have terminal hair growth. Face, chest, back, inner thighs. Facial plethora, what's that? It's that reddening of their face. Look at the back. Oh, when you're listening to their heart and lungs, you have their shirt off. No shoes, no shirt, no shirt, no oski. And you see a fatty deposit back here. Because you took off her shirt, you've noticed dark purplish striae on her abdomen. Oh man. Pelvic exam, clitoral enlargement, but otherwise benign. Okay, what do we do first? Just basic labs. Does this person get labs? Absolutely, right? This is not your familial hirsutism. So what labs again? Testosterone, DHEAS, androsterone, cortisone. Do we measure cortisone? Do you think she has excess cortisol or low cortisol? Excess. So then what do we do? Dexamethasone suppression, 24-hour urine, your salivary, awesome. And then also you want to check your thyroid, prolactin, pregnancy. What's that one lab? 17 what? Hydroxyprogesterone, rule out CAH. Awesome. Oh, but we didn't get that far because they're not rock stars like you, but they did at least get a CBC, a CMP, and ruled out pregnancy. Oh, great. Her potassium's low. Oh no, what's going on with this lady? We have hirsutism, rapid, you caught that, viralization, rapid weight gain, physical exam findings of hypercortisolism, we already knew that, possible hypokalemia, elevated blood pressure. We did the labs. What do you think? Are these scary? Yeah. Over 200 is what I keep saying for testosterone, right? But I have to tell you, would you say these are markedly elevated? Yes, severely cortisol is high, and you follow up later with an ACTH and it's suppressed. Shoot, what are we doing? Am I talking about this feedback loop? What does all that mean? So again, you caught up here, extremely elevated means worried about what? Cancer, right? I'm worried about cancer. And then this right here tells me that I have hypercortisolism or high cortisol in the blood. Where's the problem? I don't know. Is it the anti-pituitary adrenals? ACTH is suppressed. So what that tells me is the anti-pituitary is working correctly, right? Because when cortisol is high, ACTH decreases. So where's the problem? The adrenals. Okay. Don't worry. I won't put this on your chest, but it's in there. It's still in there. We're going to do some imaging. We do an ultrasound. We see a mass on the CT. So what do you think? What is it? What is it? Cancer, what type? It's not an ovarian cancer. Adrenal, right? Yeah, some kind of adrenal cancer. Here's your summary. Adrenal carcinoma. They conduct a surgery to remove the cancer or the tumor, but it's extended and her kidney, so it's spread, and she passes 2 months later. Respiratory failure and met despite chemotherapy. So super, super rare, but super, super aggressive. And maybe the death, sorry. But yeah, that's it. So we talked about 2 blocks today. I will post the last block of information